Hello, everyone. This is Team CHM. We would like to thank Pediatric Trauma Society for the opportunity to present at this platform. The title of our presentation is Pediatric Minor Head Injury, Factors Associated with Avoidable Inter-Hospital Transfers. We do not have any disclosures. Head injury in children is a common emergency presentation. Majority of these children are initially evaluated and treated in community emergency departments. Limited expertise and lack of pediatric resources often result in transfers to pediatric centers for definitive care. It has been shown that nearly 1/3 of the children with minor head injury are unnecessarily transferred. Unwarranted transfers offer little benefit, as they are not only burdensome for the families, but they also add to the healthcare cost. We have ample evidence that the incidence of clinically important traumatic brain injury in children with minor head injury is very low. We have validated PCAN rules to guide decision making, but we still continue to have so many low-value transfers. Bearing this in mind, we designed our study. Our main objective was to identify the patient and clinical factors associated with avoidable minor head injury transfers. We conducted a retrospective chart review of children less than 18 years of age transferred to our emergency department for minor head injury. We are a level 1 trauma center. We see around 85,000 patients per year. ED transfer logs were screened to identify our study population. This is the flowchart of our study population. We initially screened all trauma-related transfers to our ED during the study period. Children less than 18 years of age who were transferred for minor head injury were eligible for inclusion. If these patients were transferred for non-accidental trauma, or if they had a history of bleeding disorder or pre-existing neurological conditions, they were excluded. Our main outcome measure was avoidable transfers. For study purposes, transfers were categorized as avoidable if none of the following interventions were performed at our emergency department. It included subspecialty consultation, intubation, neurosurgical intervention, procedural sedation, admission to the ICU, or hospital admission for more than 2 nights. We collected data on demographics, clinical presentation, CT utilization, types of interventions performed, and disposition. Risk stratification and clinically important TBI were defined per PCAN guidelines. We initially conducted a series of chi-square and Mann-Whitney U tests to provide unadjusted comparisons. After that, logistic regression was used to find association between factors and avoidable transfers. A total of 1,078 transfers met the eligibility criteria and were included in the final analysis. Using our case definition, 42% of the transfers were found to be potentially avoidable, as these patients did not require any additional predefined interventions in our emergency department. This table gives you the demographic and the clinical profile of the study population. The majority of patients were male. Median age was around 4 years. More than 90% of them had associated symptoms. 1/3 of them had a severe mechanism of injury, and most of the patients were either intermediate risk or low risk for clinically important TBI. The overall incidence of clinically important TBI was low at around 3.5%. Less than 1% patients required neurosurgical intervention. The overall CT utilization for our patient population was high. 60% of these scans were performed prior to the transfer at the outside facility itself. Discordance rate in the interpretation between the transferring facility and our hospital was around 10%. Around 1/3 of the scans were positive for trauma-related findings. After comparing a series of patient and clinical factors, 6 variables were entered into the logistic regression model. These included age, gender, mechanism of injury, associated symptoms, risk for clinically important TBI, and a positive CT scan at the transferring hospital. We found that children less than 2 years of age and those at low risk for clinically important TBI had greater odds of an avoidable transfer. Positive head CT scan at the transferring hospital reduced the odds of an avoidable transfer by more than 90%. Our study had several limitations. First off, the data was retrospective and dependent on documentation. Secondly, there is no standard definition of avoidable transfers. The definition we used was based on prior literature, but it is arbitrary. Finally, we cannot comment on the role of parental preference in the disposition plan at the transferring facility. In conclusion, there is a high rate of avoidable transfers in children with minor head injury. Children less than 2 years of age and those at low risk for clinically important TBI have greater odds of receiving an avoidable transfer. We feel that this information can guide future research and quality improvement efforts to reduce unwarranted minor head injury-related inter-hospital transfers. Thank you.